Excellent. Let's do it. So, first of all, I believe we had something left from yesterday. Let me just remember for a second. Well, we finished hematology for sure, and we had to start, genetics. So we had to finish up genetics, and I see 50-50 on the pool. So somebody can choose one more thing so we can break the tie. Okay, so let's see. The last thing we spoke about yesterday, I was telling you guys about the mitochondrial disease. We spoke about heteroplasmy, and I told you what does it mean. And heteroplasmy was highly dependent on how many mitochondria are affected within one cell. And we said the more mitochondria are affected, the worse and the more severe the disease is. It's exactly the same concept as variable expressivity. The only difference between the two, that variable expressivity is on all of the diseases that are not considered as a mitochondrial disease. Today we are going to start with the disease called cystic fibrosis. This disease is super high yield. We'll be discussing it we spoke about it little bit during GIT tract, and we're going to speak about it again now, and again we're going to speak about it in pulmonology. Remember, if you have a disease affecting your lung and your liver, you need to think about alpha-1 the alpha-1 antitrypsin deficiency, which is basically the emphysema thing. And if you have a disease that affects mainly lead to pancreatic insufficiency plus lung problem, you need to think about cystic fibrosis. If you have a disease that lead to bronze diabetes, basically like the pancreas, cirrhosis, and the skin alteration, you need to think about hemochromatosis. If you have a disease that looks like hemochromatosis but it's occurring in a young patient and have encephalopathy, think about Wilson disease. So cystic fibrosis. Cystic fibrosis is an autosomal recessive disease, which means what is the chance of transmitting cystic fibrosis if we say that both parents are heterozygote for it? If both parents are heterozygote for it, what is the chance that the child is going to have it? So let's see. Heterozygote means like this. So let's try to divide them. So the first child will be like this. The second child is going to be like this. The third child is going to be like this. And the last child is going to be like this. So this is totally healthy. These two are carriers, and this guy is affected. So if both parents are heterozygote to it, it's only 25% chance that the child will actually get it. Okay, so what is the chance in a healthy human being that he is a carrier? A healthy human being. What is the chance that he is a carrier? That's a tricky question. That's a tricky question, again, I'm telling. Why? Because I told you in a healthy human being, he's healthy. So if he's healthy, can he be this guy? If he's totally healthy, can he be this guy? He cannot. So if I'm asking you, in a healthy human being, what is the chance that he is a carrier? It's 2 on 3. It's 2 on 3. And what is the chance that he is healthy? It's 1 on 3. What are the 3? 25% chance, 25% chance, 25% chance. So because we canceled this one, these 3 become 100% themselves. So this is like if 2 out of 3 or 1 out of 3. Okay, so defect in the CFTR gene on the chromosome 7, commonly a deletion of the Philadelphia 508 gene. Most common lethal genetic disease in patients of European ancestry. I want to be a little bit clear. What do I mean by European ancestry here? Yes, is the Caucasian, the white people. But to be more fair with you guys, there is a population that is more likely to have it, which is the Northern European one, like Finland, Sweden, and Norway. For the US similarly, they truly like Norway, but yeah, just think about the Scandinavian countries. Okay, so let's keep it going. Okay. They write pathophysiology, CFTR encodes an ATP-gated chloride channel. So there is this gene, the CFTR gene that we just spoke about. And this gene, it encodes for an ATP-gated chloride channel. Now comes the question, is the chloride coming in or out? The response for that question should be, it highly depends. It highly depends. So if we are speaking about the lung and the GI, this chloride channel is secreting the chloride out like to the lumen. In the lung and the GI, they are secreting it. But in the sweaty glands, they are reabsorbing it. Again, I repeat. This chloride channel in GI tract and in the lung, they are secreting it. We secrete chloride. Where? To the lumen. What about in the sweaty glands? We are reabsorbing it. So in cystic fibrosis, we have a defect in this guy. So this is the cell. I think there is a picture down here. Oh yeah, good. So you can see here that we have the sweaty glands, and in the sweaty glands, this chloride channel were responsible in reabsorbing it. While in the GI tract, it was responsible for releasing it, right? So if I tell you that a patient has cystic fibrosis with a defect in the chloride ATPase, is the chloride going to be more outside or inside of the cell? Outside of the cell, absolutely. Since the chloride is going to be stuck outside, sodium like chloride, remember sodium chloride? So sodium chloride is going to be more outside of the body on the surface of the sweaty glands, which is the skin. So the skin is going to become salty. So this is the most common complication in a mommy with a boy or a lady, little girl, who has cystic fibrosis. You know, mother have her child, she kisses him. During kissing her child, she will notice, okay, the child is salty. So when she feels that, you are like, oh, you bring him to the doctor, and the doctor, when he hears the word salty baby, he need to start thinking cystic fibrosis, and also he can do the sweat test, which we'll discuss later. In the airway and in the GI tract, however, the chloride is normally going out. So if I'm telling you that it's normally going out, chloride like what? Sodium. So there is going to be more water where? Outside of the cell. Outside of the cell. But you are like, no, I see sodium is going in. Yeah, it's going in, but when the chloride channel is defective, it will be going more in. So relatively, the sodium is still high outside. So because of that, it's going to be more water outside, but they are like, no, I see the water is coming inside. Yeah, but this arrow is much more thicker, which means here is more water coming inside. So here, the mucus is inside of the airway and inside of the GI is going to be like normal viscosity. But in cystic fibrosis, with the defect of the chloride channel, the mucus is going to become really thick. Okay, so they write, this phenylalanine 508 deletion will lead to creation of a misfolded protein. Misfolded protein, improper protein trafficking, and protein retention within the rough endoplasmic reticulum. Okay, so which protein are we speaking about? We are speaking about the basically the chloride channel protein. Protein is absent from the cell membrane, which means less chloride and water secretion, and increase intracellular chloride, resulting in a compensatory increase in the reabsorption of sodium using the ENaC channel. So yeah, if the if the chloride channel is not functioning anymore, right? There will be more sodium going in, and thus will draw more water to the inside. So more water reabsorption and abnormally thick secretion in the lung and the GI tract. Okay, so more sodium reabsorption also causes more negative trans-epithelium potential difference. So again, when you keep sucking the sodium to the inside of the body, at least sucking the inside of the body, the sodium is a positive ion. So if you keep sucking it inside of the body, what is going to happen to the electricity potential on the surface of the cells within the respiratory tract? The surface of the cells within the respiratory tract is going to become more negative. Yeah? More negative. Why? Because you are clearing out all of the positive cations, like the sodium. And this is one of the tests we can do, checking the basically transepithelial potential within the nose, which is a portion of the respiratory tract. So the diagnosis: more chloride concentration using a bilocarbene-induced sweat test is diagnostic. Remember, we discussed the bilocarbene. It was a direct muscarinic agonist, which actually increases the sweat. It can present with contraction alkalosis and hypokalemia. Why? Because, first of all, before I speak about that, the sweat test we just spoke about, it just like induces the sweat to the person to have more sweat. Logically, normally we should have sucking of the chloride, which means that the chloride concentration within the sweat should be reduced. But here, when it's humongously high, we need to think about cystic fibrosis. It can present with contraction alkalosis and hypokalemia. Remember, contraction alkalosis, it's something we discussed before. And we said it's when you have reduction of the volume, the RAS system is going to be activated, which increases the angiotensin 2, which is going to directly functions on the proximal tubule territory absorption of water and H2O. Okay, so extracellular fluid affects analogs to a patient taking a loop diuretic. So yeah, the symptoms was going to be like a loop diuretic symptoms, which is like hypokalemia and contraction alkalosis. Because of the extracellular fluid, H2O and sodium losses via the sweating and concomitant renal potassium and hydrogen wasting can occur. So we are wasting a lot of electrolyte outside. Notice it's the exact same electrolyte lost in case of loop diuretic. There is one of the tests that we can do is something called immunoreactive trypsinogen. It's only done in the newborn. So this test basically checks for the pancreatic function in the baby. And basically, if it was positive, that means that the pancreas is totally intact in this baby and he does not have basically cystic fibrosis. Why? Because patients with cystic fibrosis tend to have a pathology of the pancreas. Okay, so which pathology of the pancreas? Basically, the secretion in the pancreas are going to become super thick, which is going to clog off the pancreatic ducts. Complication of cystic fibrosis, including recurrent pulmonary infection. Wait a second, why? Because of a destruction of some system, which innate immune system is present within the respiratory epithelium. I hope you are thinking about mucociliary apparatus. So, what do you think? Is it the muco part that is affected in this pathology or the ciliary part that is affected in this pathology? Yes, which disease we had affection of the ciliary part of the pathology? I mean, of the apparatus, mucociliary apparatus. We had a disease that affects the cilia. Not Albert. It was excellent, primary ciliary dyskinesia, also known as Cartagena syndrome. Yes. Okay, good. So we have, yes, they write this patient, because of a defective mucociliary apparatus, they can have recurrent infection. Please remember, this is the cutoff, 20 years old. If the patient is more than 20 years old, they have high risk of a Pseudomonas infection. Less than 20 is Staph aureus, right? Less than 20 years old, Staph aureus, more than 20 Pseudomonas. Can we hospitalize two patients with cystic fibrosis in the same room? No, we cannot, at least 6 feet apart. Why? Because one of them can have one type of Pseudomonas and the other guy can have another type of Pseudomonas. Putting them in the same room can allow them to exchange their bacteria, which is going to lead to a worse disease in both of them. Okay, so Staph aureus for the children, as we said, until 20, and Pseudomonas is for adulthood. Allergic bronchopulmonary aspergillosis is also a serious condition. Can occur in this disease. Remember that in this one, we have eosinophilia as well. Chronic bronchitis and bronchiectasis can occur as well. Remember, please, bronchiectasis occurs when we have a recurrent biogenic infection of the lung, which lead to massive consolidation all over the lung that is irreversible. Reticulonodular pattern on the chest X-ray and opacification of the sinuses because of the basically the inflammation that was followed up by fibrosis. Nasal polyps can occur in these patients and nail clubbing. The nail clubbing, I would like to spend a moment on this. It's we recently finished hematology. You're like, why is hematology related to nail clubbing? It's a long story, but can somebody tell me where does the platelet come from? Where does the platelets come from? Which cell? Yes, you are correct. It's megakaryocyte. You are like, but I don't get it. Why you are even telling me about this? It's not related to our topic, you know? Well, actually, it's totally related. So normally, the bone marrow is creating the megakaryocyte. The megakaryocyte, the bone marrow is released into the veins. Veins go to the inferior vena cava, and then it goes to the lung. Inside of the lung, it's going to be trapped, and it's going to basically, what happens to it? What happens to it that it gets cut, create how do we call the fragments of the, how do you call the fragments of the megakaryocyte? The fragments of the megakaryocyte, how do you call them? Platelets, okay, good. So normally in the lung we have cut. The platelets are created in the lung and then they are going to the systemic circulation, perfecto. That's what happens normally. Let's imagine that one of two things happen. Either the megakaryocyte is bypassing and they are going directly to the systemic circulation, or the lung is messed up, which means basically the megakaryocytes are not getting destroyed perfectly. That is going to lead to the megakaryocyte to accumulate inside of the lung, and instead of fragmenting, they are going to release something known as VEGF. VEGF is going to keep going, and it's going to go to the most distal portion in your body. What is the most distal portion in our body? The most distal portion in our body is our fingertip and our toe tip. Okay, excellent. So when that goes there, the VEGF is going to go and it's going to lead to basically binding into the endothelial cells, which will lead to hyperproliferation of the vessels within that location. So a lot of proliferation and fibroblast accumulation is going to occur in the finger, which is going to lead basically to clubbing. I'm going to discuss this topic again when we discuss respiratory, but this is a clubbing, okay? Okay, so they write here, pancreatic insufficiency, malabsorption with the steatorrhea, and fat-soluble vitamin deficiency because the pancreas is not working. Fat-soluble vitamin are the A, D, E, and K. Progressing to an endocrine dysfunction, a CF-related diseases, and biliary cirrhosis can occur as well. Why? Because the secretion are too thick. Also, liver disease because of the liver cirrhosis. Meconium ileus can occur in the newborn, which is failure to pass meconium after 48 hours of birth. Infertility in males can occur because, this is important. They like to trick you. They give you a patient with cystic fibrosis. They tell you that he's infertile and they ask you why. And they tell you, it's because the sperm is too thick. This is incorrect. The correct answer that this gene that is defective also encodes for the vas difference. So the vas difference is going to be absent, but the spermatogenesis will be unaffected. Which means if I do direct, like if I take sperms directly from the testicles and I inject them to the oocyte, can the lady be pregnant? Yes. Okay, now the tricky question. Can these men ejaculate? I mean, do they actually have like ejaculation? That was the tricky question. Yes, they do. Remember, guys, only 3% of all of our sperm is spermatozoa. The rest of it is a fluid that is made in the seminal vesicles and other glands. But the actual sperm is only 3%. If you want me to give you a proof for that, you know what is a vasectomy? A vasectomy is a surgical procedure in which the man cuts his vas deferens. Why he would do that? Well, he don't want children anymore. So if somebody has a vasectomy, can he still have ejaculation? Yes, because his seminal vesicles are intact, so he still can have ejaculation. Okay, so let's see the next thing. The next thing that is mentioned for us here, let's see. Yes. And subfertility in ladies, they can have amenorrhea and a normal thick cervical mucus, which makes it for the sperm to be difficult to go through. Multifactorial schist physiotherapy, it's like the forms of the treatment provided. So it can be schist physiotherapy, which is this thing that they put in the chest and keeps vibrating. Or it can be done physically, but there is like this machine they wear. And while they're wearing it, they can run or do some type of sport. And where it is? Yeah, they can like just this vibration thing. Or even better, there is a machine. This machine is going to shake to shake them really, really. Yes, this one. So this machine is going to keep shaking them, which leads to a clearing out of the mucus. It's actually useful, guys. It works, and it's really, really useful in these patients. Okay. The next thing we have is albuterol, which is basically a beta-1 agonist, which lead to bronchodilation. An aerosolized Dornase alpha DNase, which is going to help to destroy the mucus, and an inhaled hypertonic saline facilitate the mucus clearance. Azithromycin used as an anti-inflammatory agent, because remember, azithromycin is not only an antibiotic, also it's an anti-inflammatory. Ibuprofen slows down the progression of the disease. Pancreatic enzyme replacement, such as pancreolipase, for pancreatic insufficiency. Okay. Combination of lumicaftor and tizakaftor each correct the misfolded proteins and improve their transport to the cell surface. Remember, we had the misfolded proteins accumulating within the rough endoplasmatic reticulum. So the lumicaftor and the tizakaftor help move that misfolded protein from the rough endoplasmatic reticulum back to the cell surface to do its normal function, which is being a chloride channel. We have ivacaftor, or I like to call it ivacaftor, because it opens the chloride channels and improve the chloride transport. It does not translocate the misfolded protein, however. Okay, the next thing, we have an X-linked recessive disease. There is multiple diseases that you can memorize using the videos I told you about from Dirty Medicine. And this is just like memorizing the stuff. It's just like you need mnemonics, you need stuff like that. Understanding the concept, that's my job. So female with Turner syndrome, 45XO, has more chance of getting an X-linked recessive disease. Why? Because she only have one X chromosome. So if she inherit only one like pathological chromosome, you need to think that, yeah, she's going to get the disease. So we have the X chromosome inactivation, the process known as leonization, super important. During development, one of the X chromosomes in each XX cell is randomly deactivated. Remember, we spoke about it, we condense it and we make it a bar body, and I told you a bar body was a methylated heterochromatin in which it is inactive. So let's say that we had like a skewed inactivation, which means like you inactivated the wrong chromosome. So let's imagine that you have 2X as a lady, and the diseased one is this. Normally you inactivate the one that is pathological and you leave the normal one, which is why ladies have much less chance of getting an X-linked disease. Let's say that you had a skewed deactivation, or they will mention it on the test, the leonization of a healthy chromosome, which is basically hypermethylation of healthy chromosome. That means you are going to get an X-linked recessive disease regardless of the fact that you are still like a lady. So if skewed inactivation occur, XX individual may express an X-linked recessive disease such as G6PD. Penetrance and severity of X-linked dominance disease in an XX individual may also be impacted. So, okay, what I want you to know in this X-linked inactivation, that if they give you a disease that is normally X-linked recessive, but a lady has it and they ask you how come she have it, the answer is that there was a process of leonization in the healthy chromosome. Okay, so let's take 10 minutes break, guys, and I will see you guys in 10 minutes. Start the recording. Okay, so you have decided to start MSK as the next system, and that is what is going to be. So let's see. Now I'm going to speak about muscular dystrophies. Muscular dystrophies, we have the three main types. Actually, in the future, you will learn that there is more, but these three are what is important for the USMLE. You must be able to differentiate between them according to the symptoms. I mean, between Duchenne, Becker, and myotonic dystrophy. Today, we are going to speak about that person that you start a handshake with, but you never can stop that handshake. So, Duchenne muscular dystrophy. It's an X-linked recessive disorder, typically due to a frame shift deletion or a nonsense mutation. A nonsense. What does it mean, nonsense mutation? What does it mean when they tell us, oh, that's a nonsense mutation? Nonsense mutation means basically when there is a stop codon. By the way, guys, can you hear me? Okay. A nonsense mutation is a type of mutation in which there will be a stop codon which is going to terminate the chain. So they write here, nonsense mutation, there will be a truncated or an absent dystrophin protein. Just a note, here dystrophin protein is totally absent. Here in Becker, dystrophin protein is partially functional. Okay? So they write here a progressive myofiber damage. The myofiber is going to be damaged. Weakness begins in the pelvic girdle muscle and progresses superiorly. Okay? Okay. What is pelvic girdle? Pelvic girdle is basically, pelvic, the area where is the buttocks, the proximal muscle to the thigh, these ones. So they write it starts from near the pelvic girdle and moves it from there. So this is the pelvic girdle and is going to move it from there. So they will have a proximal muscle weakness. Pseudohypertrophy will occur at their calf, which is this thing. Pseudohypertrophy of the calf due to a fatty fibrous replacement of the muscle. And when you do biopsy on that, you will see plenty of fat inside of it, as you can see here. So onset of the symptoms is the most important thing, because this is how you differentiate between Duchenne and Becker. The symptoms in Duchenne and Becker are kind of similar, but it's all about the severity and the onset of the symptoms. The onset in the symptoms in case of Duchenne muscular dystrophy is before 5 years old. And in Becker, it's more later, like in teenage and in the adulthood. So the causative agent of death in case of Duchenne, remember, it's a pathology of the striated muscle. Except of the skeletal muscle, what other muscle is considered a striated muscle? The cardiac muscle, absolutely. So they will have problems in creation of the heart muscle, so they would get a dilated cardiomyopathy, which is the most common cause of death. They love to ask about this disease. Which protein is defective? It's dystrophin. Which type of a mutation? It's a frame shift mutation. What is the cause of death? It is the dilated cardiomyopathy. They want you to know the Gower sign, which is the way, they will not tell you Gower sign, they will describe it, okay? So if the patient is like down, how he gets up? He has to use his hand, push them backward slowly, and his legs push them forward slowly until he can get himself up to on his leg, okay? So Gower sign, patient uses upper extremity to help stand up. Classically seen in Duchenne muscular dystrophy, but also seen in other muscular dystrophies and inflammatory myopathy, like polymyositis. So this, any disease that can lead to a huge proximal muscle weakness can lead to a Gower sign. Remember, they use their hand to help them get up on their legs. Okay, so Duchenne muscular dystrophy. They write, Duchenne muscular dystrophy will be deleted in case of deleted dystrophin. Dystrophin gene, DMD, is the largest protein coding human genes. There will be high chance of a spontaneous mutation, and this is actually important. Why? Yes, it's an X-linked recessive. But can we have it without a family history? The answer is absolutely yes, because it can be sporadic. Dystrophin helps anchor the muscle fibers, primarily in the skeletal and the cardiac muscle. When I read this the first time, I just memorized it. But after some times, I kept studying this topic so many times. Eventually, I was like, okay, enough. I have to know what does exactly dystrophin do. Dystrophin basically connect the extracellular space to the intracellular space of the muscle. This blue thing here, it's dystrophin, and it helps connecting the intracellular and extracellular matrix together. Even better. You can see how the cytoskeleton is going to bind to the extracellular space sorry, using the dystrophin gene. So the dystrophin is responsible in the communication between intra and extra cellular compartments. Okay, so just one moment, there was a better picture of this actually. Yes, that's what I wanted you to see. So this is the cytoskeleton, this is the dystrophin, and this is the dystrophin associated protein complex that basically lead to alteration of the extracellular matrix. Yes. What? Okay. Okay, so that's the function of dystrophin. It connects the intracellular actin to the transmembrane protein alpha and beta dystrofoglycan, which are part of the complex, which are connected to the extracellular matrix. Loss of dystrophin can lead to the myonecrosis and destruction of the muscles, which is going to be replaced by fibrous and fat tissue. There will be increase in the creatine kinase and aldolase. Genetic testing can confirm the diagnosis. Keep in mind that it is a frame shift mutation. In Becker dystrophy, however, it's an X-linked recessive, still the same, but it's a non-frame shift mutation, deletion. Non-frame shift. Guys, I want to warn you about something. They can mention for you a non-frame shift as this. In frame shift. is exactly the same as saying non-frame shift. Again, in frame shift is like saying non-frame shift in dystrophin gene. So it will be partially functional. So it will be much less severe than Duchenne, and the symptoms will occur much later, onset in adolescence or early adulthood. What are the symptoms? Exactly like Duchenne. Deletion can cause both Duchenne and Becker muscular dystrophies. Two-thirds of the cases have large deletion spanning one or more axons. Okay, what I want you to know, guys, that dystrophin tend to be one of the biggest genes in the world. Like between all of our genes, we have multiple genes, but dystrophin to be one of the largest gene known. And do we know all of our genes, guys? Yes, we do. And the largest one between them is the dystrophin gene. Myotonic dystrophy. Myotonic dystrophy is going to be something like this. It's an autosomal dominant disease, and also it's a trinucleotide repeat expansion, which is types of disease we'll explain here. What is trinucleotide repeat expansion? It's like when a patient has a disease, it's because a 3 nucleotide, which encodes for one codon, which means one codon, which encodes for one amino acid, is going to keep repeating themselves. So we call that a trinucleotide, 3 nucleotide, repeat themselves, expansion. So more of them. Trinucleotide repeat expansion, for example, of the CTG. Yes, this is cytosine, thymine, and guanine, but they put it in a mnemonic, which I really love. So this patient is going to have cataract, topy. Topy, it's that man that is bald from the anterior side. And G for gonadal atrophy. So just the topy, I want you to know because it's tend to be, yeah. A topy is a type of baldness. It's basically when the patient does not have hair in the anterior portion of his head. Okay? So, they're right. Autosomal dominant, the onset of the symptoms is going to occur between 20 and 30 years. CTG, trinucleotide repeat expansion in the DMBK gene. So what I used to tell myself, deleted and myotonic dystrophy. So it is an abnormal expression of the myotonin protein kinase, or myotonin protein kinase. The most important thing to know about this disease is the symptoms. It's like somebody do a handshake with you, but he cannot release. I mean, he can do the handshake, but after the hand is on your hand, he does not let go, you know? Or the other representation they put on the USMLE is the door handle, guys. Is the door handle. So this person is going to hold the door handle, but he does not let go, okay? Yes. This patient, who's between these two have the myotonic dystrophy? What do you think? The guy. The guy. Why? Look at this look. He's looking weird, right? Why? Everything is stretched, guys. Everything is stretched. This is basically the phenotype. You look at these patients and you know them from the first look. They look at you and they look like, huh? Where I have seen you before. So yeah, that look of them is highly characteristic. If you give them something to hold, they cannot let it go. They sounds like Putin. Okay, so the next thing we have here, muscle wasting, cataract, and testicular atrophy, also frontal balding. If they ask you why they die, the answer is arrhythmia. Be careful, it's not in the CTG mnemonic, but arrhythmia is the cause of death. So cataract, Tobey, and gonadal atrophy. Okay, let's speak about Rett syndrome. A lot of people have Rett syndrome actually. Who has more Rett syndrome, boys or girls? Well, let me tell you a note about this disease. Maybe it will help. It's an X-linked disease. So boys or girls? I tricked you. It's still girls. Why? Because yes, it's true that it's an X-linked disease, but The men who have one gene of it, they are dead, okay? All of them die. But ladies, they have two X's, which means if they have one mutated, the other one will compensate for it. So they are going just to get sick, they are not going to die. But for men, if they get Rett syndrome, they die in utero. You will never see them in your clinic. It's like, what is the most common trisomy, guys? What is the most common trisomy? So everybody think it's Down syndrome. They are like, well, chromosome, it's a trisomy 21. That's Down syndrome. It's the most common trisomy. You are kind of correct. It's the most common living trisomy. It's 21 followed by 18, and the least common is 13. So what is the most common? The most common is 16. But you are like, I never heard about the trisomy 16. Yes, you did not. Why? Because all of them die in utero. You will never hear of it because all of them are dead, aborted. Okay. Sporadic disorder, almost exclusively in females. Affected males die in utero or shortly after birth, so you will never see them. Most cases caused by de novo mutation of something known as the MECP2. Sadly, you have to know the name of the gene, which is located on the X chromosome. Symptoms of Rett syndrome usually appear between age 1 until 4 and are characterized by regression. What is regression? Regression, we'll speak about it in psychiatry. It's getting into a previous, it's like when you finish a milestone, you go back in time. For example, we'll learn a little bit in reproductive about this stuff. At which age should the baby start speaking? Telling you, mama, baba. At which age? No, not at 2 years old. It's too much. Not even at 1. At 1, he start to say 3 words. At 9 months, he should, like 9 to 12 months, he should at least say mama, papa. At 12 months, he should say baba, mama, and a new word, a third word, which should be like, for example, dada, dada, or boo boo. Okay? So, okay, let's say that we have a child, a female child, that she is like 4 years old. She should be able to speak by now, make small sentences, correct? But now they tell you that, and she should be able to walk as well, because at which age we start to walk? I'm not saying crawling. Crawling happens early, but walk. At which age we start to walk a little bit? Yeah, between 1 to 2 years, absolutely. So at 4 years, of course, she should walk, but they tell you, oh, she's crawling again. So she used to walk, but now she's crawling. She used to speak, but now she's saying mama, dada, baba. That's regression. Okay? Regression is going into a previous milestones. So regression in motor, so the walking, for example, verbal, the language or cognitive abilities, and ataxia as well, and even seizures, growth, deceleration, and the stereotypical hand wringing that I must show you. I always have a problem finding this video. I hope that I can show it to you in real life, but it's, yeah, I cannot. So let me just hopefully, good. Take a look at this girl. See, take a look at her hand. See, this is the movement. Okay, perfecto. So let's see. Yes, this is the ringing movement. See? Is it reversible, guys? Is it reversible? I mean, all of these symptoms. Sadly, no. It's just going to get worse from here. Can we help them in any way? The answer is yes. You can basically train them to be in one type of it's not about USMLE, but in general, people with many like of these diseases, for example, Rett syndrome, schizophrenia, stuff like that, we don't give up on them. There is always something to be done for them. For example, autistic patient, you can find a job for them that will keep them busy, but in the same time, like, make them participate into the community. That will make them feel good about themselves. And at the same time, they actually doing something for the community. So it's a win-win type of situation. They will feel satisfied psychologically, and the community will have a benefit out of them. So yeah, keep that in mind. We always try to contribute such patient in the community. It's not a death sentence to have a disease like this. Well, actually, yeah, they might die from this, but still, we can always try to help them. Fragile X syndrome. Oh, yeah, they like this one. It's also a trinucleotide repeat expansion, but this time, so myotonic dystrophy, we spoke about the CTG, it was autosomal dominant. And the Fragile X, it's an X-linked dominant disease. So can father give it to his son? Impossible, because father gave the Y chromosome, not the X chromosome. Can father give it to daughter? Yes, always. Okay, so a Fragile X syndrome, an X-linked dominant inheritance, a trinucleotide repeat expansion of the FMR gene. Hypermethylation of the cytosine residue will lead to decreased expression after we have this trinucleotide repeat expansion. The hypermethylation disorders is going to basically inhibit the functionality of the gene. Most common inherited cause of intellectual disability. You are like, I thought it was Down syndrome. Yeah, that's true, but that is not inherited. Down syndrome is not inherited. I mean, that's an interesting question. If the father has Down syndrome, can the child have Down syndrome? Oh, well, rare. Well, regarding this question, you should be like 99% of all Down syndrome patients cannot have children. Only 1% can, which are the mosaic people. But if the father has Down syndrome, his child is highly unlikely to have Down syndrome because it's not inheritable disease. Okay? It is sporadic. It's just a failure of the non-disjunction. No worries, we'll speak about it in today's class. So, yes, the most common genetic cause is actually Down syndrome, but most cases occur sporadically. So, of the intellectual disability, if we are speaking about the inherited one, like getting from mommy and daddy, this is going to be Fragile X. Fragile X can be transmitted. So it's a trinucleotide repeat expansion of the CGG. So CGG, what is this? The shin is going to be protruding and giant gonads. Okay. So, but they are stupid. I used to have this study partner. She used to tell me he's an idiot with big balls, and I was like, okay. So yeah, pre-mutation. So it depends on how many repeats. The more repeats means worse prognosis and worse symptoms. I have a question about this, by the way. How do we call it when this man is going to have symptom, but his son is going to have worse symptom, and earlier, it occurs earlier, and his grandson is going to even have it worse? How do we call it? What is the genetic term of a disease that is getting worse by each generation? And it's a trinucleotide repeat expansion. Well, I hope you are thinking about anticipation. Anticipation is when a disease getting worse by each generation. Like if we speak about the first generation, yes, it's bad, but the next generation is going to have it earlier and it's going to be worse. And like that. Why? Because they have more trinucleotide repeat expansion. Pre-mutation 50 to 200 repeats can have tremor, ataxia, and primary ovarian insufficiency, which can lead to sometimes to basically absence of menstrual cycle in the ladies and can become infertile, the ladies. So they write here, postpubertal macroorchism, which is big testicles, long face with a large jaw, large everted ears, and autism. Important cardiac findings include mitral valve prolapse with a mid-systolic click and hypermobile joint. So let's take a look at it. Sometimes they can have a little bit of a, this patient, okay, they can have also self-mutilation. I want you to notice, see the averted ears? This guy, yeah, it's like that guy in your school that used to be with you, but yeah, for some reason he did not go to college, and he's a good guy, by the way. It's not a bad guy, but yeah, interesting one. The big ears. Search for a big ears. So they are really interesting people, but sometimes, sadly, they have self-mutilation. Self-mutilation means they harm themselves, okay? Because of that, you need to be, oh, see, their IQ is around 40 to 50, which is really bad. So they can do self-mutilation. Remember, please, that self-mutilation is also associated with Lesch-Nyhan syndrome, but in Lesch-Nyhan syndrome, we have totally different other symptoms. Trinucleotide repeat expansion may show genetic anticipation, disease severity increase, and the age of onset decreases in successive generation. We have Huntington disease, which we'll speak about in neurology. So in that one, you will be hunting, and after you hunt, you will put the animal in a cage, C-A-G, cage. So hunting and put him in the cage. So autosomal dominant, so he will have a caudae degeneration, which is a basal ganglia, a structure inside of our brain, and they will have less acetylcholine and less GABA. Put him in a cage after hunting him. Myotonic dystrophy, we spoke about this, and we have a Fragile X. Fragile X, we just spoke about it. These have like the protruding chin, intellectual disability, and giant gonads. Lastly, Friedreich ataxia will be also mentioned in neurology. This patient will have ataxic gait, diabetes, and ataxia, obviously, and they will die around 25 years old. Okay, the next one is, how do we call when we have an extra chromosome or one less chromosome? How do we call this disease? One extra chromosome, a trisomy, one less chromosome, we call it a monosomy. But like both of these are considered as aneuploidy. Aneuploidy. Autosomal trisomy. What is the most common trisomy, guys? No, it's not 21. I said it's not a 21. It's 16. Why we never hear about it? They die in utero. Yes. So Down syndrome, it's a trisomy 21. It's actually the most important thing to know about the Down syndrome. It's association. Findings include intellectual disability, flat faces, and prominent epicanthial folds, which is above their eyes. And previously they were called like Mongolian eyes. And single palmar crease. If you look at your hand, you can see that the creases in your hand looks like this. It's like this and like this. And on the other hand, it will be like, I'm cheating right now, but it looks like this, okay? So it is like this and like this, or like this and like this, okay? Yep. So, or, okay. So, they say, by the way, guys, if you don't know why we have these creases, it's because you're like when you twist your hand like this, like since all of your life, you will have formation of this crease. I mean, notice only you have the creases where you have joint. You only have the creases where you have joint because it's the place where you twist your joint. Okay, so incurved fifth finger and gap between the first and the second toe, known as also like the sandals finger. Duodenal atresia and Hirschberg disease, we spoke about this. How you differentiate between meconium ileus and Hirschberg disease? Do you remember? Yeah, but I'm speaking about a physical examination finding. Absolutely. Rectal examination, the squared sign. You put one finger inside and you pull it out. If you will have explosion, like a lot of feces coming out. So what is that? Hirschberg disease. But if nothing is coming out, it's meconium ileus. Okay, congenital heart disease, including ASD and sometimes even VSD. Brushfield spots, this is important to see. So Brushfield spots. So I hope you know what is like a brushing net that we... Yes. Can you see this little dots? Dot, 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 the white one. And here you can see them, I hope. Yeah, they are actually quite beautiful, but yeah, this is a sign of Down syndrome. Guys, the moment the baby is born, I mean the same second he's born, can you say for sure that he has Down syndrome? Like, just from how he looks like, it's a little bit difficult. He does not have the phenotype yet. He does not have the epicanthial fold. He does not have these. But the Brushfield spots, you can see them early on. A really good physician, like a person who's a specialist in this stuff, can search for all of these findings. But you, as like a clinician, you have just to search for these most of the time, because it's always there. Okay, so these patients also have increased risk of what? Early Alzheimer's disease. Why? Because I will speak in neurology that Alzheimer's disease is actually caused by an amyloidosis, local amyloidosis inside of the brain. Excellent. And it's because the amyloid precursor protein, yes, is encoded within the chromosome 21. All of us have 2 chromosome 21, but these patients have 3 of them. Also, these patients have an increased risk of AML and ALL as cancers. Remember, the acute ones. So it's the more severe ones. 95% of cases are due to meiotic non-disjunction, and most commonly during meiosis 1. Increase with advanced maternal age. So the older the lady, the more chance she's going to have it. So in the total population, it's more than 1 over 1,500, but in ladies more than 45, it becomes 1 over 25. So let's take a look down here and try to understand what is meiosis 1, meiosis 2, and non-disjunction. Well, meiosis 1, it's when the chromosomes are separating from each other. And in meiosis 1, look, they are supposed to separate like everyone to its side. But here a non-disjunction had occurred, which is, well, the separation did not occur in meiosis 1. In meiosis 2, the separation occurs again. And now what happens? When this separation occurred, on this side, what do we have? One from this, one from that. Okay, the yellow ones. But what about the other one? Nothing. Why? Because all of them were skewed to the other side. So this area will get a trisomy, while this area will get a monosomy. Okay? So the chance of getting a monosomy is 50%. The chance of getting a trisomy is 50%. The non-disjunction, when it occurs at the second phase, at meiosis 2, obviously, anytime the symptoms occurs later, the prognosis is better. Okay? So you can see that initially everything was perfecto, but the non-disjunction happened at the meiosis 2, the second division. So here at this side, everything went perfectly. So we had in the end, 50% of the people are going to have what? Normal chromosome. But 25% of them are going to have a monosomy because of the non-disjunction. They are only going to include this because remember, what is this meiosis? It's just division of the cell. So yeah, some of them are going to have 1, the rest are going to have 1, 2, 3. 3 alleles. So they are going to have a trisomy. So 25% for trisomy, 25% for monosomy, 50% for normal. So if we discuss this, only 1% of the cases are due, 4% of the cases are due to unbalanced Robertsonian translocation. So what is this translocation? It's basically that a portion of the chromosome is going to be translocated or moved from chromosome 14 to chromosome 21. And that is Robertsonian translocation when you transfer some chromosome from chromosome 14 to 21. That will lead to more material for that chromosome 21 to deal with. And that will lead to Down syndrome. The least common is like post-fertilization mitotic error. And it's a type of highly associated with a somatic mosaicism. Which one between these three, I mean mitotic non-dejection, unbalanced Robertsonian translocation, and somatic mosaicism can have children? Only the somatic one. Only the somatic one. So only the somatic one can have children. It's like the person I showed you about yesterday. So incidence is 1 in 700, and the drinking age is 21. So that help you to remember like drinking 21. And most common viable chromosomal disorder and most common cause of genetic intellectual disability. Okay. So first trimester ultrasound commonly shows increased nuchal translucency on their neck, and that's an ultrasound finding, and when the doctor see that, he becomes scared. And also they can have hypoplastic bones. Let's take a look at that. So what can we see? Okay, can you see the nuchal translucency here? It's like his neck, there's something black in his neck. I hope you can see it here. It's here. Normally this should not occur, okay? Okay, so this is a normal baby and this is our baby. He has the nuchal translucency. When you see that, this is highly suggestive of Down syndrome. Okay. Okay, so when you see that, you would like to do some tests. So there is markers that you can check. So the markers are including HCG and inhibin. So yeah, sometimes you go down, but then you go high, okay? Don't forget about high. It's going to save you on the exam. So in Down syndrome, you are going high, HI. So that it means that the HCG is going to be high in Down syndrome, and the beta HCG, which we said high, and inhibin is going to be high. What about the other ones? The other ones are low in every single other disease and also in the trisomy 21. So to make it simple for you, you only have to know about the Down syndrome, that it's high, down high, and basically it's going to be high, HI, high beta HCG, high inhibin. Okay, the A's of Down syndrome: advanced maternal age, more risk, atresia of the duodenum, atrioventricular septal defect like ASD and VSD, also Alzheimer's disease because of the beta amyloid gene location, AML and ALL. Edward syndrome. It's a chromosome 18, the Prince Eduardo. The election age is 18. I remember that Eduardo was allowed to sit on the throne when he was 18 years old because he's the prince. So Prince Eduardo, prominent occiput, their head will be looking like an alien, okay? And the rocket bottom feet, it's not characteristic of this one, it can be in this one as well. Intellectual disability, non-disjunction. If I was you, I would just remember the prominent occiput and the clenched fist, okay? They have this clenched fist with an overlapping fingers, as you can see here. No other disease has this. And low set ears. Also, they have really small jaw, okay? Micrognathia means a small jaw. And also they can have a congenital heart diseases such as VSD, ASD, and omphalocele as well, which is, I hope you remember. Did we have a sac over the intestine in case of omphalocele? We did. Seal. I told you, seal, it's like sealed in a sac. And gastroschisis, we did not. Myalomeningocele. Yeah, omphalocele had a poor prognosis because of this actually. Because omphalocele is associated with extra-intestinal pathology, while gastroschisis is not associated with extra-intestinal pathology. Myalomeningocele also can occur in the back of the patient. Death occurs within the first year of life, the same with Patau syndrome. Okay, so let's take a look at Eduardo. Okay, you can see the clenched hand. This is the most important finding. they will not live long. They will live for around 1 year and that's it. This is the prominent occiput I told you about. So most likely, like at least for the USMLE, you need to know small jaw, prominent occiput, and the clenched hand. That's what you need to know. The other findings are much lower yield, but these three findings you must know. Okay, let's take a look at the next one. The second most common autosomal trisomy resulting in a live birth. The most common is Down syndrome. The most common one is Down syndrome. Regarding of what they said, live birth, because if they said the most common one overall, it will be which one? Absolutely. In Edwards syndrome, every prenatal screening markers decreases. So if you take a look here at Eduardo, here, low, 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 low. So in the first trimester, we only check the beta HCG and the BABB. The BABB is a marker for the trisomy. It does not really matter which one. It's a marker for all of them. Okay, so they write here Batau syndrome. The findings include severe intellectual disability, the rocker bottom feet, the microphthalmia, which is a small eye, and microcephaly, cleft lip or palate, and holoprosencephaly. So the microphthalmia is small eyes. Microcephaly is a small head. Cleft lip and palate, it's like small, sorry, not small, but the cleft, it's like, I just show it to you. It's like when there is a fissure. The rabbit, we call it like the rabbit lip. Yeah, this one. Cleft lip, and it can be in the palate as well. Yep. Guys, is this bad? I mean, okay, it does not look perfect, but is it bad? Does it have other problematic stuff? I mean, yeah, but it looks like it's not the nicest thing, but is it leading to an actual life-threatening condition? Actually, yes. What? Or like what? It looks totally innocent. How can it kill the baby? Well, yeah, but this is a baby. And if he drinks milk from his mommy, where the milk will go? Into his nose. And he can accidentally do what with the milk? Aspirate it. And if he aspirated, he can get aspiration pneumonia. Yeah. So that's why when you see this, it's no joke. You have to fix it. I mean, the lips is okay, but the palate is a big problem. Okay. So they write here. Batau syndrome. Yeah, we spoke about the problem. So we'd have rocker bottom feet again, severe intellectual disability again, microphthalmia and microcephaly, small head, small eyes, cleft lip, palate. Holoprosencephaly is super high yield. What is it? Well, inside of our brain, we'll speak about it in neurology. We have something called the prosencephalon, which is the thing that gives you your two hemisphere of your brain. Okay, so the holoprosencephalon, it's going to lead to one big ventricle. By the way, guys, you see this guy in Shrek, I think. You know this guy from Shrek. Is he real? I mean, is there any disease that can lead to something like this? Yep, there is. Yep. So let's take a look at which disease they are speaking about. It is boom. See, sometimes the separation cannot occur correctly at the midline. That will lead to one eye. Will this baby live? Sadly, no. Most of them will die super young. Most of them die like during birth. Some of them can live for 1 month, 2 months, but they cannot live for long. And they have this holoprosencephaly, which is just one big ventricle inside of their brain. You remember the ventricle is the thing that contains the CSF inside of our head. Okay, so they can have multiple fingers, cutis ablasia, which is like a bunch out lesion from the skin. Does anybody remember a medication that led to this, cutis ablasia? A medication. Hint, it's in endocrinology. Medication that led to cutis ablasia. Cutis ablasia, it's like when one portion of the skin is absent. Any idea? It's a thyroid medication. Methimazole. Methimazole, guys. Methimazole was an anti-thyroid medication that can lead also to this thing, cutis ablasia. Okay, so congenital heart disease can occur as well, polycystic kidney disease, and omphalocele again. So it's a defect in the fusion of the precordial mesoderm, leading to a midline defect. Do not worry too much about what is a precordial mesoderm now, because this topic is for reproductive. But basically, there is something called mesoderm, and when these two mesoderm connects with each other, they help to basically locate everything in your body in its place. When that fails to happen, you will have the midline defects, such as holoprosencephaly, cleft lip and palate, congenital heart diseases, omphalocele. All of these are caused because of a midline defect. Okay, at the first trimester, we can check these two in the amniotic fluid. Can check the beta HCG and the BABB. If this was altered, that means you truly have trisomy. If it was normal or high, you are fine. Okay, so we are done with these ones. We understood them. You only had to memorize the high. The other ones are low, right? So in the second trimester, again, you have to memorize high. The other one is low. There is only one thing that I would like to add on this. There is something called alpha-fetoprotein. Do you remember in which disease it will be high? Alpha-fetoprotein is actually going to be high in hepatocellular carcinoma. They would love to trick you on this. They will show you a patient with a high alpha-fetoprotein, but they will totally jump you off by telling you hepatocellular carcinoma, because hepatocellular carcinoma marker is alpha-fetoprotein. Other cause that can lead to an increase in alpha-fetoprotein is a neural tube defect. Okay? Okay, good. So let's see. The horrible table that everybody hates. So this table, you must print it in a small paper, put it in your bathroom for the sake of you to memorize it. So each chromosome mutation, multiple mutation, and each mutation encode for one disease. Each of these genes is located at different chromosome. For example, chromosome 3, renal cell carcinoma, 3 letters, von Hippel-Lindau VHL, 3 letters. So these are chromosome 3. Autosomal dominant polycystic kidney disease, that's chromosome 4 and 16. Okay? And we have achondroplasia, speak about it in MSK, and Huntington disease. Hunt is 4 letters. 5 is Cri-du-Chat, which is this disease we speak about later today. And Fab is chromosome 5. Hemochromatosis is 6. And Williams disease, a disease we'll speak about later today, and cystic fibrosis, they are at 7. William without the S is 7 letter. 9 will be Friedreich ataxia. Or tuberous sclerosis, both of these are in neurology. 11, Wilms tumor, beta globulin gene defect, such as sickle cell disease and beta thalassemia, and MEN1. Chromosome 13, Batau, obviously, Wilson disease, and retinoblastoma, and the BRCA. BRCA2, because BRCA1 will be 17. 15, it will be the Angelman and the Prader-Willi and the Marfan. 16 is going to be, again, autosomal dominant polycystic kidney disease, alpha thalassemia, and tuberous sclerosis type 2, not type 1. Type 1 was 9. Neurofibromatosis type 1 will be 17, 2 will be 22. And BRCA mutation, yeah, I felt it. Okay, neurofibromatosis is 17 letters. Yeah, okay. And BRCA and TB53 also is chromosome 17. Eduardo 18, Down 21, 22 will be neurofibromatosis type 2 and DiGeorgi syndrome. X-linked, so all of the X-linked diseases, Klinefelter, X-linked gamma globulinemia, Fragile X, but not only, all of the X-linked disease. Okay, so let's speak about Robertsonian translocation. Chromosomal translocation that commonly involves chromosome pairs 21, 22, 13, 14, 15. One of the most common types of translocation. It occurs when the long arm and two acrocentric chromosome. Acrocentric, guys, what does it mean? It's this thing. Just a second. Yes, this is a chromosome. Notice that this area, which is the centromere, which is where they connect with each other, it's near the terminus, right? It's near the end. That's an acrocentric chromosome. So they fuse at the centromere and the two short arms are lost. So what they write? We have balanced and imbalanced. Balanced translocation means no gain, no loss. So, well, that will not be our deal. Normally do not cause an abnormal phenotype because it's balanced. But the unbalanced one is our job. Unbalanced translocation, missing an extra gene, can result in miscarriage, stillbirth, or chromosomal abnormality, most importantly, Down syndrome and Battau. So the Robertsonian translocation, let's take a look. We have two chromosomes. They are acrocentric, means this division is located near the end. So what is going to happen? Look, Robertsonian translocation. We are exchanging these guys, right? So when we go here, we have this thing. It's an unbalanced translocation. Basically, it's messed up. And this is going to be in which disease? Down syndrome or Battau. So the next one is cri du chat or the cry of the cat. Cri du chat, cry of the cat, it's a congenital deletion on the short arm of chromosome 5. So we have 46XX or XY. So yeah, but you just need to know about the chromosome 5. And yeah, it occurs at the short arm, and they write the 5P here. What does it mean? Well, the B means short arm, Q means long arm. When I write for you 5B, it means at the location 5 at the short arm. So finding will be microcephaly, moderate to severe intellectual disability, high pitch crying. I will not do it, but it sounds like a cat. I mean the cry. It's like that I cannot do it, but it's a high pitched crying like a cat. And the epicanthial fold like those with Down syndrome. The crying cat-like sound is the thing that is going to get you the answer in the exam. And cardiac abnormalities such as VSD. The last disease is Williams syndrome. William is 5 letters without the S, which is chromosome number 7. Congenital microdeletion of the long arm, which is the Q, on chromosome 7. The deleted region include the elastin gene. So the finding will be variable, including the elfin facies, intellectual disabilities. First of all, I would like to show you a picture of this. Guys, do you watch Dexter? Dexter does. There is a guy called Dexter. Yeah, the guys who have Williams syndrome are quite friendly, but Dexter was like a serial killer. And anyway, so yeah, they are quite friendly. They are like, invite me to your home. Not really. They are really friendly people. It's like this person who you can speak with for 16 hours and you know that he's a good guy. He's not going to like harm you, hurt you, or do anything bad for you. He's a good person, okay? So these people are really good people. They are always smiling. They are. It's difficult to get them depressed, basically. But what is the problematic thing? They do have intellectual disability, but that's not the problematic thing. The problematic thing is what can kill them. So they can have hypercalcemia. This is important. Well-developed verbal skills. You know, this person, literally, he can come to anybody, start a conversation with him out of nothing. Actually, before I learned about this, I never saw a person like that. After I learned about Williams syndrome, I start seeing them everywhere. So this is how you get it. When you learn something, you start observing it more often around you. So search for that person that he really know how to speak and he is really friendly and a good person and you would like to have him as your buddy. So well-developed verbal skill, extreme friendliness to stranger, don't forget about the intellectual disability and the cardiovascular problems, which include supravalvular aortic stenosis. The problem is not in the valve, but the sound will be exactly like aortic stenosis, which means they are going to have a crescendo decrescendo murmur, but you know where it's normally located. It's systolic. It should be at the second right intercostal space, but because it's supravalvular, it will be at the first right first intracostal space on the right. Yes, crescendo decrescendo murmur at the first intercostal space on the right. So supravalvular aortic stenosis. It's the only condition that has this, so you don't have to worry about other conditions. You can see the stenosis is occurring after the aorta, right? Okay, they can also have renal artery stenosis with this bruit over it. Good. So, okay, done with genetics. What else do we have? I just wanna share with you what we are doing. So we have nutrition. Nutrition is like 5 pages or a little bit more than 5, maybe 6, 7 pages. It's super small. We can finish it in one lesson actually. MSK is a little bit long. It will need 1 week to be done with it. What I was thinking about, because it was like some people choose nutrition, some people choose like MSK. I was thinking maybe we can do both of them in the same week. Like we'll start it tomorrow, like on Thursday. By next Thursday, we'll be done with both. I mean, both nutrition and MSK will be done. Okay? And we can even start the next thing. That seems like we can start both of them at the same time. They are really short. I mean, nutrition is super short, super easy. Yeah, I agree. Metabolism sucks. Metabolism will be your enemy. This is the most difficult. This is why people hate biochemistry. Is because of metabolism chapter. So it will be actually our last one. It's not for now. It's a little bit later. And yeah, that's how my plan, like to do MSK with nutrition, and we will have four system left. So okay guys, for now I think that's it for today, and we will continue with you guys tomorrow. So see you tomorrow.